my name is Yasi Xiao, and I'm one of the Advanced Endoscopy Fellows at Advent Health Orlando at the Center of Interventional Endoscopy.
And I'm Dennis Yan, Director of Third Space Endoscopy here at CIE. As part of the author interview series, it is our pleasure on behalf of our co-authors to discuss our multicenter study on the use of a novel self-assembling peptide gel to prevent esophageal stenosis after endoscopic submucosal dissection.
Endoscopic submucosal dissection, or rather known as ESD, has become an increasingly endorsed technique for managing superficial neoplasias in the esophagus.
However, the main drawback of ESD in the esophagus is the high rate of stricture formation, particularly when the postmucosal defect involves more than half to 3/4 or complete circumference of the esophageal lumen.
Currently, there hasn't been any single effective prophylactic agent for stricture prevention.
A novel self-assembling peptide gel that forms an extracellular 3D matrix upon contact with fluids has been recently introduced commercially as a novel endoscopic hemostatic agent. A recent pilot animal study has suggested that this gel may be effective for the prevention of esophageal stenosis after ESD in the esophagus.
The aim of our multicenter prospective study was to evaluate the self-assembling peptide gel and stricture formations in patients undergoing extensive esophageal ESD. Patients that undergo esophageal ESD with a post-resection mucosal defect involving more than 50% of the esophageal circumference were included in our study. Immediately following ESD, this self-assembling peptide gel was applied onto the mucosal defect under visualization, and all the patients were scheduled for repeat endoscopy at follow-up between 4 to 8 weeks after the initial procedure. A total of 43 patients were enrolled and included in our final analysis. Out of these patients, 5 of them underwent circumferential ESD, and 21 had a mucosal defect involving more than 75%, but less than 100% of the circumference. The remaining 17 patients post-ESD defect involving 50 to 75% of the esophageal circumference. In terms of the baseline characteristics, the median lesion was 30 millimeters, with most lesions located in the distal esophagus or at the GE junction. The median resected specimen was approximately 5 centimeters in size. Median ESD time was approximately 70 minutes, whereas gel application took about 4 minutes. En-bloc resection was achieved in nearly all cases. There were 3 cases of delayed bleeding managed endoscopically. There were no cases of perforation, and the most common histopathology encounter was Barrett's esophagus with high-grade dysplasia and T1A adenocarcinoma. At follow-up, the overall rate formation was 21% within our study population. When stratified based on the extent of mucosal defect, stricture formation developed in 80% of those who had circumferential ESD, but stricture formation only developed in 19% of those with at least 75% involvement of stricture formation. The stricture rate was low at 6% for those patients who had a mucosal defect between 50 and 75% of the circumference. In conclusion, this self-assembling peptide gel was associated with relatively low rate of stricture formation following extensive esophageal ESD. The potential advantages of this gel includes an easy one-time intervention with high safety profile without any adverse events.
We should still highlight that circumferential ESD was associated with a high rate of stricture formation and thereby should probably be avoided unless absolutely indicated. Prospective studies comparing the self-assembling peptide gel and other prophylactic measures should be considered for future investigation. Once again, on behalf of all our co-authors, we want to thank you for watching this author's interview and certainly encourage you to read the rest of our manuscript at the GIE journal for this month. Thank you.